how can healthcare, this is a general question, I think, to all three of you. We will see how the question goes before we decide who answers. How can healthcare providers close the gap between patient expectations and reality? How can the trust gap in the private sector get closed, where in many cases there's lots of unneeded diagnosis? So this is perhaps one from the insurance point of view as well. And excessive medication, perhaps over, what do you call it, a prescription of antibiotics, for example, or something. Prescribed to increase revenues of primary care in the private sector. So we've got two questions. One is this one about how can healthcare providers close the gap between patient expectations and reality. So.
Sure, I can tell you quickly what we do at Daman. We started measuring utilization from facilities and from clinicians about 2 years ago. Looking at, and we try to do it using data, big data, to understand what's a fair benchmark. So we compare peers, so we only look at specialists, we compare a specialist endocrinologist with another specialist endocrinologist, and we even look at the diagnosis of the patient. So we're comparing similar patient case mix with the same specialty, and create a benchmark for that based on all the data that we have in Abu Dhabi and Dubai, which is substantial. And then measure their performance relative to that, and create an expected behavior, and compare that to their actual behavior. And then draw the range of deviation from that. Some would be above, some would be below. And anyone who exceeds the 75th percentile, so these would be the worst or the top 25%, get warnings. Just a letter that says, look, we've noticed this behavior. It doesn't appear to be appropriate based on our analysis, but we invite them to come in, give an explanation for it, and we can accept the explanation if the medical doctors think it makes sense. Otherwise, we expect the behavior to change, right? And it's true, a lot of this behavior is financially driven. And we see dramatic changes. Simple warning letters or notifications of concern immediately lead to changes in behavior and some substantial savings.
And presumably, Dr. Osama, you talked about the initiative to benchmark outcomes. Presumably, have you seen do you work with the Jauda one in
We do.
And does that make a difference in these issues?
Right, so Jauda is sponsored by the Health Authority in Abu Dhabi. It's mostly self-reporting data, so hospitals report directly to the Health Authority, and they compile a score based on that, which they'll be sharing quite soon with insurance companies.
And so the initiative that Dr. Osama has talked about in Dubai Healthcare Authority, that's the same.
Yes. It's the same concept, right?
And eventually we will publish data to the public, so they can know exactly which hospitals are better in certain specialties, and this will support their decision. So rather than just talking to friends to get recommendation, you get some evidence-based data.
And I don't know enough about who the Jauda system is aimed at, if it's the consumer or the medical practitioners. The question here was about consumer expectations. Yes. So these things will be easily available to me or to consumers. So I can see how this hospital performed or this doctor. And
yeah, I think in the long run, that's certainly the plan. One of the key issues you have to work out when you're measuring quality is to make sure that you're adjusting properly for risk, right? So that's one of the things we built in from the beginning in terms of our own measurement from claims data, the risk. So public hospitals tend to score poorly at first if you just look at outcomes. But when you start to compare what was the condition of the patient when they entered the hospital in the first place, their outcomes become much better. So that's really key. So before you can start sharing the data, you need to make sure that it's completely fair and reflects reality. So consumers really have to be discerning when they read these. I'm sure the government will be careful when it publishes this data, and we ourselves take great pains to make sure that it's a fair comparison.
Yeah, but this overdiagnosis, when it comes to overdiagnosis, of course, there'll be regulatory surveillance, there will be insurance surveillance, but we believe, being here for the last 44 years, it should be self-surveillance. It should come from the organization, that what is that we are going to do, and how can we ensure that the entire system doesn't get manipulated to only get the financial gain. We have around 1,400 doctors working with us. We have all the doctors working with us, like full-time salary doctors who doesn't get a revenue share of doing something else. And we also put specific, indicators for the doctors. For example,
Again, I don't know enough about the detail of this, but over prescription or over medication,
Exactly.
is that
it's a big issue.
is that driven by financial motivation, or is it because there's a culture of the patients like to go away with some solution?
It's a combination of various factors, but end of the day, in an environment where we are all talking today, I'm not talking about 10 years, 15 years down the line, but we are all used to a system whereby doctor is the ultimate word in that particular exchange of information that happens in the doctor's chambers. Nobody else can, change the thought process of the patient. So we put internally some sort of a strategy, measures to them that what should be our total pharmacy billing to the total billing that happens, or like how many of our patients who walks into the pediatrics will not have antibiotics. So we put some, or like the number of C-sections we have on the total number of, how can we reduce the C-section to the total number of deliveries happening in, as a specific target along with that to the doctor. So we have divided our entire portfolio business up to me as a CEO. Below me there are two power points for us. One is the chief operating officer, who takes care of the operational initiative of the business. We have a chief medical officer who takes care of only the medical or the clinical aspects of it. There is a push and pull happening on that end. If there is no proper internal check and balances in the system, any healthcare industry can definitely slip into that type of overdiagnosis, which will definitely affect the entire population.
So you have some targets or some numbers that you would see as a normal pattern, or where you should be a bit like
Exactly.
Daniel's description about and I guess it ties in with the whole benchmarking. Do you do it just within the NMC group of hospitals,
Exactly.
or can you go beyond that into international standards
No, we can-
and wider?
We have an analysis of that. That's what we know. We have a team that works on the quality departments team. We have a quality strategy team that fully works on not only comparing the UAE peers, but also going into the healthcare developed economies in the world.
Okay.
How do that pattern works in that particular
So
place?
for C-sections versus
To the normal deliveries.
delivery, you can compare.
Yeah,
each hospital.
it's not a fully comparable, because you look at UAE as a country, we have like 200 nationalities living into that. So there is a genetic disposition to many of those treatments. So we need to really, as Daniel said, you cannot compare apple to apple. There's no comparison of apple to apple in healthcare. So, but we can only give some sort of a benchmark, some sort of a bandwidth on which they need to play, depending on the medical situation. But the clarity should come from the top to down in healthcare industry, that the intention is to make the entire industry sustainable, and to ensure that the ecosystem where patients, providers, and the insurance provider, regulator, all works in tandem to the ultimate goal of achievement of the best healthcare indices.